Hi guys, good morning everyone. So shall we start our cornea quiz discussion? So last evening at 6 we did have 10 questions from cornea which we're going to discuss now. All right, one second. Let me just open. All right, so the first question that we are going to discuss from the cornea quiz. A 16-year-old female presented with complaints of gradual decrease in vision in the right eye that improved with a trial of hard contact lens. The most accurate diagnostic modality for this patient. So what do you think is a diagnosis that you have in your mind? Only then, see, only when you have a tentative diagnosis in your mind, you can ask for an investigation. Yes. So what do you think is the diagnosis in this 16-year-old female? Is had a complaint of gradual decrease in vision. There's no mention about pain or painless. Okay. So just this, and the vision is improving with a hard contact lens. So hard contact lens is useful whenever you're having an irregular type of astigmatism. Yes. So a teenager decrease in vision, gradual, and which is improving with hard contact lens. What do you think is the diagnosis here? Excuse me. So what do you think is the diagnosis? So I've told you irregular astigmatism. That is when we are using this hard contact lens, or a combination of hard and the hard which has a good gas permeability, a rigid gas permeable lens. So the diagnosis here is keratoconus. So what is the best or the most accurate diagnostic modality for keratoconus? So probably what we are trying to ask is a one-liner investigation of choice for keratoconus. So they've given you a presentation of a keratoconus kid and asking you what is the diagnostic modality that you would choose, or the investigation of choice for keratoconus. So if I ask you investigation of choice for keratoconus, you won't even look at the options, right? You won't even look at the options, right? What would be the answer, guys? Put it in the chat box. Let me see. And in the meantime, I will read out the options for you. Option A, corneal topography. Option B, pachymetry. Option C, anterior segment OCT. Option D, gonioscopy. Everybody knows gonioscopy has no role in keratoconus. In fact, sometimes you can actually see the angle structures in very, very advanced keratoconus without even the need for a gonioscope, because the whole total internal reflection is compensated or overcome by the increased curvature to the cornea itself. Okay, that's very, very rare, very, very rare. Don't take that as, like gospel truth and it's going to work in all cases. No. So gonioscopy, no. ASOCT is, you can see certain changes of keratoconus. You can see that the cornea is thinned out, or probably if you're having high drops, all that you can see. Yes, very good. Beta. Sagar, very good, Sagar Chaudhary. It's corneal topography. Yes. Pachymetry, yes, you do see some changes on pachymetry, but that is not the most accurate thing for diagnosing keratoconus. Yes. All right. It's not that bad, but I'm just taking some precautionary measures so that it doesn't get aggravated, doctor. So thank you for your concern. Okay, because yeah, with time, there are a lot of things that happen and you want to take care. All right. So please keep me in your prayers. Shall we move to the next question? So the next question is fifth nerve palsy could cause. What is fifth nerve? Fifth nerve is fifth cranial nerve is your trigeminal nerve, right? So option A. So option A is ptosis. Ptosis has nothing to do with trigeminal nerve, no? When will you get ptosis? Which cranial nerve palsy will you get ptosis? Please don't mind this, guys. My throat is bad. Thank you, Babu Raji. All right. So ptosis, when do you get, yeah? When do you get ptosis? Which cranial nerve palsy do you get ptosis? Second, third, fourth, fifth, or seventh, your favorite seventh. Which cranial nerve palsy do you get ptosis, bache? Put it in the chat box. Let me see, and then we'll move on to the actual question. So fifth nerve palsy could cause ptosis. I know for sure it's not ptosis, and you are going to tell me which cranial nerve palsy causes ptosis. All right, next option, lag of thalamus. What is lag of thalamus? Lag of thalamus is Incomplete closure of the eyelid. What muscle enables closure of the eyelid? Your orbicularis oculi. Orbicularis oculi is innervated by your facial nerve. So if I have a facial nerve palsy, I will not be able to close my eyelid properly. So that is called lag of thalamus. So definitely not my answer here, because my question here is about fifth nerve palsy. All right. Option C, neurotrophic keratitis. Yes, neurotrophic keratitis. I've told you trigeminal nerve. Take the T, trigeminal, neurotrophic. So trigeminal nerve is the one which is innervating your cornea. So when you have a trigeminal nerve palsy, your cornea is not innervated properly and it doesn't get the nourishment also, because there are some neurotrophic factors which are released by the corneal nerves. So that is gone. So if that is gone, the epithelium is unhealthy. The corneal epithelium is unhealthy when you have a trigeminal nerve palsy for whatever reason. Okay, so you can get a neurotrophic keratitis. So our answer is option C. Fifth nerve palsy could cause neurotrophic keratitis. All right. Now, what about option D? Exposure keratitis. When is my cornea exposed and I'm going to get corneal inflammation? When I get lag of thalamus. When do I get lag of thalamus? In facial nerve palsy. So, option B and D are related to facial nerve palsy. Is that clear? So, lag of thalamus is inadequate closure of the eyelids, which could result in exposure keratitis if my Bell's phenomenon is poor. All right. And coming back to the question I've been asking you, ptosis is seen in third nerve palsy, in your oculomotor nerve palsy, because oculomotor nerve supplies your levator palpebrae superioris, LPS. So LPS is the one which is going to open your eyelid or lift your upper eyelid. So if that's not working, there's going to be ptosis. All right. So shall we move to the next question? Yes. Thank you, doctor, please do pray for me. Really. It hurts. All right. A patient presented with decreased vision in the right eye on examination, branching linear corneal ulcer is noted. The best treatment would be. So I've just described it to you. So it's like, we're sitting in a cafeteria and we're talking and I'm saying, yeah, today I saw this patient, and this patient had, and especially when you're a new resident or you're a house surgeon, you're seeing something new, I have no clue of ophthalmology and you're describing this. And I heard the consultant saying there's a linear branching ulcer. What is a linear branching ulcer? What are they actually discussing? What are we actually describing here? What is the diagnosis? Only if you know the diagnosis, we can answer the question, because the question is entirely different. The question asks the best treatment would be. So I have to have a diagnosis. What is a diagnosis, guys? So I'm reading for those of you who joined late. A patient presented with decreased vision in the right eye on examination, branching linear corneal ulcer is noted. So what is this branching linear corneal ulcer that we are describing? Yes, especially residents, when you have to go for a presentation, you have to put that, no? See, otherwise we won't even bother to describe this. But when you're going for a case presentation, you'll have to write all this. So the is about branching corneal, linear corneal ulcer. What is the diagnosis, guys? Excuse me. What is the diagnosis so that we can decide on the treatment? Yes. Okay, let me read out the options for you. So maybe when I read out the options, you'll have an idea of what we're talking about. So option A is dexamethasone and acyclovir. Option B, acyclovir. Option C, acyclovir and homatropine. Option D, acyclovir and timolol. So the diagnosis is, excuse me, sorry, dendritic corneal ulcer. Okay, so dendritic corneal ulcer is a branching tree. Okay, so linear branching corneal ulcer. So dendritic ulcer is caused by herpes simplex virus, most commonly type 1. Yeah, assuming it's a true dendrite. So it's a herpetic ulcer, viral corneal ulcer. So for a viral corneal ulcer, dendritic ulcer, what is the treatment of choice? You all know it is topical acyclovir. So now there are a little, you have to read the options very, very carefully now. Option A, dexamethasone and acyclovir. That is something I would give for a stromal keratitis. This is not a stromal keratitis. Okay, so this is neither nummular or disciform. The description itself tells us it is a dendritic ulcer. So in dendritic ulcer and geographic ulcer, steroids, topical steroids are contraindicated. So option A is contraindicated. You should never give dexamethasone. That's out. Option B, acyclovir. Yes, seems good, no? Acyclovir seems to be a good answer. Yes. But look at option C, acyclovir and homatropine. See, whenever we have a case of corneal ulcer, we always give a cycloplegic. Yes, there is ciliary muscle spasm, there would be, because some amount of iritis or iridocyclitis would be there. So you want to relieve that. So it's always a non-specific management. Although drug of choice, yes, is topical acyclovir, we always give a topical cycloplegic along with it. So although acyclovir is a good answer, but the best answer, which I would actually be giving to my patient, see, just giving acyclovir and homatropine, it makes a lot of difference to the patient, yes, in the management. So the best answer here is option C. Those of you who saw option B and then went and clicked B, you got a minus mark. But anyway, don't worry, nowadays even with minus mark, you do get a NEET PG seat. Get a seat, but I'm not worried about the seat here. I want you to learn ophthalmology. So learning ophthalmology, the best is option C. Yeah. Alright, what about option D, guys? Acyclovir and timolol. There's no mention about increased intraocular pressure, and with dendritic ulcer, the intraocular pressure does not rise. Only in disciform keratitis, we have the increased risk of having a secondary open angle glaucoma, right? Okay, next question is a very, very simple question. Ulcus serpens. Ulcus serpens is seen in, or ulcer serpens, also known as creeping corneal ulcer. Where do you get creeping corneal ulcer? Which organism causes a creeping corneal ulcer? Creeping corneal ulcer is seen with Streptococcus pneumoniae, that is pneumococcus. Yes. So ulcer serpens or ulcus serpens is seen with pneumococcus. Okay. All right. So that is Streptococcus pneumoniae. What about option A, Corynebacterium? No. So there's no two answers about it. There's just only one answer. Pneumococcus, Mycobacterium, tuberculosis. Guys, see, GB for us in ophthalmology can cause uveitis. Okay, it can cause uveitis, not this chota mota and all. It doesn't cause. It goes bang inside. Anterior uveitis, it can cause. Posterior uveitis, it can cause. Yeah, but this kind of keratitis is very, very rare with Mycobacterium tuberculosis. All right. Now, and some of you love that option, all of the above, because you thought, okay, Madam is trying to give a new question, new learning experience. So yeah, so maybe all the three and all of the above. That was just a it's just to distract you. Okay. Yeah, me also. Yeah, what to do? Yeah, I'm also having back pain, neck pain, every pain. Okay. Let me finish my quiz questions. Symptoms of corneal ulcer are all of the following except, okay, so which of the following is not a symptom of corneal ulcer? Pain in the eye? Yes, there is pain, no? Yes, there is pain. Why do we have pain? Because of the ciliary muscle spasm. The ciliary muscle spasm causes the pain. All right. Watering? Yes, we do have watering. Mucopurulent discharge? No. Let's see option D, redness of eye. Yes, we do have redness of eye. Mucopurulent discharge, very, very rare. Okay, very rare, extremely rare. Mucopurulent discharge means most of the time it's only conjunctivitis. Yeah. Sometimes, yes, you can have kind of watering, but not a mucopurulent. We don't call it a mucopurulent discharge, just watering. Okay, because the increased tear production, you can have watering. All right. So, which is not seen in corneal ulcer? Mucopurulent discharge. See, yesterday's quiz we discussed mucopurulent discharge is a feature that is seen in bacterial conjunctivitis, in chlamydial conjunctivitis. Yeah. All right. Next question. The deposits seen in arcus senilis is composed of. What is this arcus senilis, guys? Arcus senilis is that white ring that you see in the periphery of the cornea, just within the limbus, right? In old people, you see them either as a complete white ring or an incomplete ring. So that arcus senilis, what is the deposit? It is cholesterol or lipids, yeah? So lipids that you see in the Bowman's membrane and also in a little bit of the anterior stroma. So it is composed of lipids. What is option A? Hyaline. No, hyaline. Hyaline is for your granular dystrophy where there are stromal deposits of hyaline. Calcium. Calcium is your band-shaped keratopathy. Not this one. Lipid. Yes, none of the above. Okay, so the answer is lipids. Shall we move to the next question? All right. Bullous keratopathy involves dysfunction of. See, bullous keratopathy is a very, very extremely painful condition. All right. So when it's an extremely painful condition, why? Because you've got bulle. Bulle means like, in derma, you've read the bulle, no? Like that bulla. Yes, vesicles. It's not as huge as the bulle on the skin, but even the vesicles on the cornea, the epithelium, they are called bulle only. They look like small vesicles. So those fluid-filled ones are the bulle. Bulle are in the epithelium. Okay, but does that mean my question's answer is epithelium? Because my question is asking, bullous keratopathy involves dysfunction of. That means which layer is dysfunctional? See, the epithelial layer is not dysfunctional, although it is manifesting some signs. Essentially, it's the corneal endothelium that is dysfunctional. Yeah. Why? I mean, for whatever reason, this dysfunction is not working properly. So, when it's not working properly, what's going to happen? Your endothelial pump is not functioning. So, when the endothelial pump is not functioning, the water is not moving back into the aqueous, which normally happens. From the stroma, the water is pushed back into the aqueous. Now, there's no way for it to happen because the endothelium is dysfunctional. So what happens is water moves again, it moves anteriorly into the epithelium. So you've got bulle in the epithelium, which makes the whole thing very painful, and there's a decreased vision as well. So bulle, yes, they are present on the epithelium. But my question which is asking about dysfunction, which layer is dysfunctional? It's endothelium. Is that clear? So bullous keratopathy involves dysfunction of epithelium. Nah, bulla on epithelium, but dysfunction not epithelium. Bowman's layer, no. Descemet's membrane, no. Endothelium. Okay, so the endothelium, which is the vital layer of the cornea, that is dysfunctional in bullous keratopathy. All right, moving on to the next question. Dense scar of the cornea with incarceration of iris is called, okay, nebula. Nebula is first of all not at all a dense scar. It's a very superficial scar, the most superficial scar, and there's no iris involved in that. Okay, so out. Nebula is already out. Anterior staphyloma. Now this becomes a little dicey. I feel like I want to mark anterior staphyloma because when you read the definition of staphyloma, you've seen this incarceration of iris there. So that makes my head roll around now. Okay, maybe option B. Option C, adherent leucoma. Now I'm stuck between B and C. Now look at D, iris bombay. Iris bombay is just the forward bowing of the iris. It's neither stuck anywhere, it's not incarcerated anywhere, and is not associated with the scar of the cornea. So I know it's option A is out, option D is out, and I'm stuck between B and C, which is, I give it to you, okay? So I'm not saying you are wrong in, guys, how could you make this mistake? All right? So it's fine. So now let's analyze the question. Dense scar of the cornea with incarceration of iris. See, incarceration of iris I can have in anterior staphyloma. But anterior staphyloma, there should be, we're talking about a bulge of the cornea or ectasia of the cornea. We're not talking about a scar. Got it? When I'm talking about a dense scar of the cornea with iris incarcerated or stuck to it. Yes, caught in it. That is an adherent leucoma. Do you understand why the answer is not anterior staphyloma? Because some of you actually ping me saying, ma'am, why is it not anterior staphyloma? I said, just wait, hold on. 11 a.m. Shanti se baat karenge. And I will tell you why it's not anterior staphyloma, but adherent leucoma. See, leucoma is a scar which is involving more than 1/2 of the stroma. Okay, when it's a deeper and a denser scar, it's completely opaque scar. Yes, so that is a leucoma. So leucoma, and to the leucoma when the iris from behind is stuck to that, or rather than using the word stuck, I've just used the word incarcerated, which is fine, right? So please remember, if it's an ectatic cornea and you got this incarceration, probably you can even have a scar, but it has to be ectatic. Only then it's a staphyloma. Okay, staphyloma is like a grape. Okay, so it has to be a grape. And also please remember, when you have that dense a scar, you won't be seeing a black grape. You'll see a white grape only. Okay, so all right, so get it. Hello, Ravi ji. All right, so let's move to the next question. Corneal transparency is maintained by all except, one of the favorite topics of the examiners at all levels. Now, option A, unmyelinated nerve fibers. Yes, it does contribute to the transparency of the cornea. Yes, very much, because the nerve fibers are not myelinated. Option B, uniform spacing of the collagen fibrils. Which collagen fibrils are we talking about? The stromal collagen. True. Relative dehydration of the stroma. Yes, the relative dehydration of stroma because of the endothelial pump action. Yes, that also contributes to the corneal transparency. Option D, increased mitotic figures in the center of cornea. Why, man? Why there are mitotic figures? No, there are hardly any cells. The keratocytes themselves are very, very few in the stroma, and in the central stroma, very few cells. And you don't have these antigen presenting cells in the central stroma. I mean, the central, not the stroma, central cornea. So, where is the question of these highly mitotic cells, and therefore the highly mitotic figures? No way, no. So that is the false statement, because the question asked, corneal transparency is maintained by all except option D. Yeah. Next question, congenital corneal opacity is seen in all except. So you're looking at a newborn baby and there's a corneal opacity. So this is possible in which of the following conditions, and in one of the options it's not possible. So let's look at the options. Option A, Hurler syndrome. Yes, Hurler syndrome is a mucopolysaccharidosis where you do get a congenital corneal opacity or a congenital cloudy cornea, which is true. Peters anomaly, yes, you do get a congenital corneal opacity along with a congenital cataract. So that is true. Posterior polymorphous dystrophy, yes, it is an endothelial dystrophy which presents at birth. So, which is true. What about option D, Hunter's syndrome? Yes, Hunter's syndrome, I taught you in the morning, to hunt, you need to see clearly. Okay, a hunter, shikari needs a proper vision, no? So he cannot have a cloudy cornea or a corneal opacity. He has to have a clear cornea. So the question is, congenital corneal opacity is seen in all except. So that means, where do you get a clear cornea? You get a clear cornea in Hunter's syndrome. Is that clear? So that's a very, very important question. All right, so that finishes our 10 questions from yesterday's quiz. And this evening at 6, we do have the lens quiz, and those 10 questions I would be discussing tomorrow at 11 here. And guys, there is a February discount that is going on, and I guess it's there until 12th or 13th of February on the EyeMentor app. And how to download the EyeMentor app and check out the prices I've given in the description. And you can also check out on eyementor.store to look for your discounted prices, or to order your books directly with the discount coupons. So you might even get a cashback or an instant discount on the eyementor.store. So you can directly go and get your discounts there. All right. And please make sure to download the app so that, the team can give you access to the contents immediately. All right. So if you have any further questions, I will see you tomorrow at 11 when I discuss the lens questions. Okay. So all the best for the lens quiz this evening at 6 p.m. guys, and you all have a good day. God bless you all.